Good evening, everyone. This is Dr. Gary Rads. I am a practicing general dentist in Denver, Colorado. And tonight I am here to share with you making sense of the world of cementation. There are a lot of different cement options, and there's a lot of different restorative materials out there, so it can get confusing. And what my hope is in the next hour, I can distill some of this information down and help you clinically to make better, more informed decisions on cement choices and hopefully eliminate some of the confusion that exists in this world and make it a little bit simpler for you. Along the way, we'll try to share techniques that I've used in the past to help make my life easier and more efficient. On the screen right now is my email address, and you are certainly welcome to send me questions later on. If there's something I was not clear about, you are welcome to use that email, and it is there for your purposes. During the program, there is a chat function on here, and if you can use that to submit questions, when I get to the end of the program, I'll go back, look at the questions, and depending on the amount of time we have, I'll answer as many of those as I can get through. So here we go. Maybe forward. There we go. Got my buttons figured out. Okay, so every presentation has to start out with pictures of the speaker's family. So this is my family, this is my kids. If you see my wife, just let her know I put the pictures up of the kids. Quick bio and background on me. This picture of downtown Colorado, behind the clump of trees on the right, is my office. I am in a 40-story building in downtown Denver. And that's where I was speaking from tonight. Given the time frame, for those of you listening live and not recorded, this is my second week back in the office since the state-mandated shutdown of dental practices. So we are back in the office, not quite at full capacity, probably running at about 50%, getting ready and used to the new and strange world that's becoming our new normal after the COVID instance, COVID shutdown. Not that's going away anytime soon. So I'm back, I'm practicing, seeing patients, and coincidentally just cemented Emax crown right before I walked in the room. So like many of you, I practice all day, every day. Some other things I do of interest. I am a faculty member at the University of Colorado School of Dentistry. I've been there for a long time and always good to share with the students there. Belong to, serve on a number of editorial boards, worked with the AACD. Educational background is undergraduate at the University of North Carolina, and then after that completed 2 different general practice residency programs. I am one of the founding members of Catapult Education, and I've been working with Catapult for 10, 15 years now. And what Catapult is an educational organization made up of dental educators who present programs throughout the country, certainly a lot on the internet lately. But also we work with manufacturers for product development, product testing. One of the reasons I feel competent in talking about restorative products and cement as tonight is I've had the ability over the many years to work with a lot of different companies and work with a lot of manufacturers on product development, including cements over the years. So I feel like I'm fairly well educated in that background and can talk a little bit about the options of there. And then one of my other outside the practice jobs is I'm on the board of directors at a company called SmileSource, which exists to support independent dentists maintain, grow their independent dental practices. So that's kind of this. I have this slide in here mostly to remind me it's a matter of disclosure. This program is supported by Bisco, and you will see a lot of Bisco products in here. And it's mostly because when I'm cementing things, I use an awful lot of Bisco products. So it's an easy company for me to present on because I'm very familiar clinically with the product line, not just academically, but everyday use. So when we're looking at cementing a crown, there are a lot of factors we have to take into consideration when we're choosing our cement. Right now, there is no one universal cement on the market that is all things for all different types of restorations. So we need to break this down. So when you're going through your clinical thought process of, I've got a crown in my hand, I've got this prep, how am I going to attach the two? What's going to give that crown the best chance of long-term survival? We need to break down a number of different things, risk benefits of each of those different factors, combine those into making the best clinical choice for that particular patient. And sometimes the best choice might not be the only choice. There may be two best choices. But there's things we need to think about as we're looking at that tooth that we prepped and how are we going to attach the crown made out of whatever material we decided. So first and foremost, one of the things we need to keep in mind is retention and resistance form. That is a significant factor in cement selection, and we'll talk about that in a second. The other challenge is we have a number of different types of materials that we're trying to cement into the mouth, and some materials respond better to certain cements than others. Are we cementing or are we bonding to place? Those are two different factors that we need to look into. The type of tooth structure, are we cementing to dentin? Are we cementing to enamel? That is a consideration when choosing the cement. And then the aesthetics, will our cement have an effect on the final shade of the restoration that we're putting in place? So first, I want to talk about retention and resistance form, and this goes back to Crown and Bridge 101 in dental school. We learned about retention and resistance form then. I'm going to refer back to it frequently during the next hour, but we need to understand what we're talking about here. So first of all, how much retention and resistance form do you have is subjective in nature. Okay, you can't just measure the wall, the axial wall of a prep and measure the angulation, say, oh yeah, now I have to use this. It's a relative term, it's subjective as to what has good retention resistance form versus what has poor. But it's based on the length of the axial walls and the angulation of those axial walls. The closer those are to ideal, the better your retention and resistance form. And one of the things occasionally we will do as a profession, I certainly do clinically, to improve retention is place retentive grooves into the axial walls to increase the surface area if and when needed. But diagrammatically, two extreme examples of what we need to look at when we're looking clinically. Long axial walls closer to being parallel, that means really good retention and resistance form. With that kind of crown prep, there are certain selections of cements that are going to work really well. What's more concerning and where we have to look closer at the cement we use is when we have poor retention and resistance form. Because with poor retention and resistance form, now we are relying on our cement to really help us keep that crown into place. If you have good retention and resistance form, we have lots of different options in cements, and we can look at other factors to give us a better choice in cements. But when we have poor retention and resistance form, that starts to immediately narrow the number of different types of cements we can use, because adhesion of our cement to the tooth and the restoration are going to be more critical when we have poor retention and resistance form. So as I refer going forward to retention and resistance form, think back to this diagram, and this is what I'm talking about. So currently in dentistry, we've got a number of different materials we can make a crown. And when I say crown, I'm referring to crowns and bridges. But we have a number of material choices when we're looking at a crown. Traditionally, gold and PFM have existed forever. For probably all of us, our entire career, we've had the option of gold and porcelain fused to metal as a crown option. So there's a long history of cements that work well there. More recently, zirconia is making a big impact on the market. Zirconia, because it's a newer material, there is a lot of confusion there that I'm hoping to eliminate by the time we're done. But zirconia does have a lot of applications. It's an extremely popular material right now. A lot of dentists are using it, and when cemented properly, can be a great restoration and give the patient a very long service time in the mouth. The other very popular material for crown and bridges is lithium disilicate, most commonly known as Emax. Emax by Ivoclar. There are other lithium disilicates on the market, but Emax has a bulk of the market. So going forward, I'll probably refer to lithium disilicate as Emax. Another fairly new product and an extremely popular product. And another great product that can have a great lifespan in the mouth, especially when cemented correctly. And then the fourth category that's a little bit different when we get to the cementation part, and it's not as widespread used as the three above, but used enough that we do need to spend a little time talking about it, and that's feldspathic porcelain, which a vast majority of the time is used in porcelain veneers. So we will discuss that material. So we have those four types of materials, and we have really 5 different types of cements. And we're going to try to figure out as we go forward which cement's going to work with that particular product. But in the world of cements, currently, there are other subcategories, but there's glass ionomers, been around for a really long time, have a long track record, are very popular because of the fluoride release potential. So those exist, been used for a long time, have a good track record. RMGMI, resin modified glass ionomer. This is an enhanced glass ionomer that uses some resin technology to improve the bond strength of the material while still having the fluoride release. There's a new cement category called bioactive, and bioactive itself is a term that's very popular in dentistry right now. We'll discuss it a little more as we go forward, but you will start seeing cements talking about bioactivity or bioactive potential. And those are a little bit different. And we're going to separate those into a different category and talk about their applications as we go along. And then with bonded luting agents, now we're talking about where we're going to use a dual or light cure resin along with an adhesive to bond the cement to the tooth as well as the restoration. And then the evolution of dual and light cure resins has been the recent development of self-adhesive resins used as a cement. And that's probably the newest category of cements. And we're going to talk about their application and where they work best as well. So with the cement selection, as I mentioned, glass ionomer, traditional, been around a long time. It's got a really good track record. Very, very user-friendly, very friendly to the tooth. And again, the fluoride release has made that a popular material for a long period of time. Similar, resin-modified glass ionomer is popular. In the bioactive group, there's a newer cement on the market called Ceramer by a company called Doxa, a small company out of Sweden. Ceramer talks about it having the bioactive potential. And what bioactivity is, it's the ionic exchange that might lead to the creation of reparative tissue. The ions within the cement will interact with the tooth substructure to result in the formation of a bond between that tissue and that material. And cements that are bioactive are going to have fluoride in them. They're going to have calcium in them. So technically, under the loose definition of bioactive, glass ionomers and resin-modified glass ionomers are bioactive in their nature. But the bioactive cements that are now on the market and being promoted as such, their focus is not so much on fluoride, but the benefits of having calcium release within that cement, because calcium has some very beneficial effects on the tooth surface itself. And that's where we're taking advantage of the bioactivity, and that's why it's generating a lot of interest within the profession. And then bonded luting agents or resin cements, traditionally for many years, a dual cure or light cure resin used in combination with a etch prime bonding system, whether it's total etch, self etch. We'll talk about that as we go forward. Very traditional materials, got a good track record, probably 25 plus years. And it's the way many of us for a long period of time have been cementing all ceramic restorations. Self-etch or self-adhesive resin cements are the evolution of resin cements where the etch prime bond part that we would do before, cementing to place with the resin cement, the etch prime bonding component has now been combined with the resin component, and it will be a dual cure resin component to make it a one-step process. And we'll talk about the advantages and disadvantages of this technology and these type of cements. But when we're bonding something in place, what we're doing is creating mechanical and chemical bonds to the tooth and to the restoration to give us the best possible retention of that particular material. So we're taking advantage of adhesive technology, adhesive principles to bond. Traditionally, it's been porcelain, but we'll talk about its other material applications beyond porcelain. To bond that to place to ensure that we've got stability, long-term stability, and actually adding some strength to the porcelain material as well. The other factor that we won't talk about a whole lot more, except right here, is aesthetics. Will the shade of your cement alter the final shade of your restoration? So on PFM and gold, we really don't have to worry about that. On zirconia, not so much. But on all ceramic, Emax, lithium disilicates, and certainly on feldspathic porcelain, the color of the cement will affect the final restoration. That effect could be positive. It might be negative. So we need to take that into consideration as well. So start off with the more traditional gold and porcelain fused to metal. if you have good retention and resistance form, we've got decades of clinical experience saying that just about anything will work. I'm so old, initially, the first crowns I put in were with zinc phosphate cement, which is a terrible cement. But those crowns will last years, if not decades, if you have good retention and resistance form. So that's one of the keys here. If you have good retention and resistance form and you have a PFM or gold restoration, the door is wide open for you to pick basically any cement you want. Any cement will work. Those will hold into place. And again, just going back to the history of zinc phosphate, which was such a poor cement material, withstanding years and years of clinical experience of that material working, you're in a real open space when you're looking at that particular situation. So for me personally, if I have good retention and resistance form, I'm cementing PFM or gold. Lots of times I will defer to glass ionomer or resin modified glass ionomer. One, the potential fluoride release, so possibly help reduce the chance of secondary decay. Two, it's very user friendly. If you have sub-G margins and the tissue is really hard to control, and you've got you've got some bleeding there, and it's a challenge to get that controlled, glass ionomer is very user friendly. And in these less than ideal situations, it will still work well. So certainly I look at that situation where if I can use glass ionomer or RMGIs, I'm going to go that direction in that particular situation. And then the other clinical consideration is just the ease of cleanup. These two materials clean up very easily. So I can cement with glass ionomer or RMGI and walk out of the room, know that my assistant will clean it up well, and have to spend very little time coming back into the room to ensure that the cement has, in fact, all been removed. So it's a very user-friendly material in the right spot with the right material. If we have poor or compromised retention and resistance form, now I'm going to do other things. Now I need to look to my cements as to what cement is going to help me overcome this poor retention and resistance form and give my crown a better chance of staying in place. So I'm going to take extra steps, and we'll talk about these a little bit later, but different steps in treating the metal so I can increase the bond strength of my cement to the metal. And I want to increase the bond strength of my cement to the tooth itself. So when I'm doing those sort of things, now I'm looking at resin cements, be it dual cure resin cement or be it a self-etch dual cure resin cement. Those cements have higher bond strengths. And when I'm in a compromised situation, I'm going to look to those cements to help me give a better chance of my restoration staying into place. And in a little bit, we'll talk about the different steps you go through to ensure you're going to have the best bond strength. Zirconia is fairly new to the market, maybe 10 years old, probably can go back 15. But in the last 5 years, we've seen the use of zirconia absolutely skyrocket. It's become a very popular material for a number of different reasons. One, just cost, simple enough. It's a less expensive restoration to fabricate a less expensive material in its raw state. So as we're all becoming more and more price conscious when we're doing crowns, and as zirconia has improved in its quality, yet been reduced in price, a lot of us, myself included, have gravitated to using a lot more zirconia, and a lot of us are using less porcelain fused to metal and gold and replacing that with zirconia restorations. And zirconia is a wonderful material. It's got some really awesome properties to it. Aesthetically, the strongest material we have that can look like a tooth. So there's certainly a place for it. And obviously, if you look at the numbers, more and more dentists are using zirconia. Zirconia is a bit of a challenge, though, because you'll look at it as a tooth-colored restoration, and some people automatically think, well, it's all ceramic. It's EMAX. It's a lithium disilicate. But when you're cementing this into place, it's not. You need to think of zirconia as far as your clinical decisions for cement, think of it as white metal versus anything being all ceramic. Okay, your cementation part of this is way more like metal than it is ceramic. So we need to learn how to properly treat zirconia to give it the maximum strength of whatever cement we're going to use. So going down the list here, the shade of the cement rarely is going to make a difference in zirconia. Zirconia is a fairly dense material, and even the most opaque cements, I'm not seeing the show through on their zirconia. The zirconia tends to block out that shade. That being said, zirconias are getting A, more aesthetic, but B, more translucent, which is leading to the aesthetics. And as the zirconia continues to improve, there will come a point in the time in the near future where your cement can, in fact, impact the color of your final shade. So this statement is true today, but 2 years, 5 years down the road may not be true. So as far as cement selection, if your tissues are really well controlled, frequently my cement of choice is a self-etch resin cement. If I've got good retention and resistance form and the tissue's good and healthy, no reason not to use a self-etch resin cement. You've got good bond strength, you are going to bond to your zirconia, you will bond to the tooth structure, you will increase the retention of your crown with the cement because of the chemical and mechanical bond formed with the self-etching resin cement. If the retention and resistance form is compromised, now I may go to a dual cure resin cement or a self-etching resin cement, still use that. The reason difference between the two, a dual cure resin cement is clinically proven to have higher bond strength to the tooth and to the restoration than a self-etching resin cement. So if I have a really short clinical crown and my retention and resistance form just is not good, but I had no other choice, and think your crown prep on a lower second molar. Oftentimes we all get stuck in a situation where we just don't have a lot of axial wall, but the tooth needs a crown. Those are the kind of situations I'm talking about here. So if I need the maximum bond strength that I can possibly get from the cement, that's a dual cure resin cement. But if my retention and resistance form is pretty good, not great, but it's pretty good, self-etching resin cements can work really well in that particular situation. And that's where I go back to the earlier slide saying this is very subjective as far as what's pretty good and what's great and what's poor. The retention resistant form will constantly be a subjective clinical call. If the patient has a high caries rate and we have good retention and resistance form, there are times when I have cemented zirconia with glass ionomer or resin modified glass ionomer. Zirconia is strong enough, it does not have to be bonded into place to have its strength enhanced. The compressive strength of zirconia is excellent alone by itself. So in an ideal situation, lots of times, the use of glass ionomers can work very well in that particular situation. And then the other thing to take into consideration when we get to the bottom of our list here is if I have a tooth that after preparation has been very sensitive in the temporary phase, one of the things I may look at is using a bioactive cement, which has the potential to calm down an irritated tooth. So materials such as Ceramer, taking advantage of its bioactive properties, or Theracem, which is a self-etched dual cure cement, but it also has calcium release present in it. So it has the ability to stimulate and calm down irritated pulpal tissue. So if I have a sensitive tooth, now I'm looking at that. So as we're looking at all these things, I can see where it gets confusing for a lot of people. What do I put where? And it's really hard for me to give you hard and fast rules as to which cement in which situation, because there's so many different factors involved. And this is just showing the use of zirconia over time. So the blue line is, this is the use of all ceramics or all tooth-colored materials. So this is zirconia and lithium disilicate and those categories of materials over time. And this is data and it's old data, but it shows the trend. The blue line is Emax and zirconia. The orange line is PFMs. These are the number of units generated from Glidewell Lab, which is a great sample size, being that they're one of the largest, if not the largest lab in the country. This shows from 2009, 2013, a significant decrease in PFM, a significant increase in zirconia and lithium disilicate. And that trend has most certainly continued to the point that a few years ago, Glidewell no longer makes PFM crowns because the demand just is no longer there. So one of the things we want to talk about when we get to zirconia is zirconia. The challenge with zirconia is how do you get a cement to bond to zirconia? There was a point in time where it was pretty popular within the dental industry to say you can't bond to zirconia, which we found out just is not true. But what you do have to do with zirconia is you have to treat it correctly to create a surface where you can get mechanical and chemical bonding to happen. So what I want to do is walk you through the process of what we're going to do to treat zirconia so that we can get the maximum bond strength of our cement to that material. And one of the critical components of that is using a primer that is made to provide a surface treatment to enhance the bond of your cement to the zirconia. So Bisco makes a product called Z Prime, and Z Prime is fabricated to provide the surface treatment to enhance the bond strength of cements to a number of different materials, zirconia primarily, but also alumina, Procera, if anybody's using that anymore. Really any metal you're going to use. So specifically, we'll talk about PFM and high noble when we get to that point. Can be used for composites. That's not something a lot of us do. Zirconia metal or fiber posts, it will enhance the bond strength of that. Intraoral repairs. Very important, though, is the contraindications. Z Prime is not to be used with feldspathic porcelain, which is typically a veneer, or lithium disilicate Emax. So this is really, really important that you get the Emax part, because I know a lot of people listening are doing Emax and zirconia. And sometimes you put them on the table and you can't tell which one is which. And the treatment of the two materials before you cement is very different. So you need to know when you sit down to deliver that crown, what type of crown is it, so that you go through the proper pre-cementation protocol. And we will get to that protocol momentarily. So Z Prime, easy to use, is a single component. Just place a drop inside the restoration, let it sit for a few seconds, air dry it, and you're going to be ready to cement. There are some competitors on the market. I don't have experience with them, but these are supposed to do a similar process. So down in the bottom left-hand corner, I've got listed some competitors on the market that can provide the same treatment. But this graph shows the addition of Z prime to the cementation process and the increase in bond strength that happens. So on the left is using Z prime, on the right of the graph is without Z prime. But if you look at the difference in bond strength of cement to zirconia, when you use Z prime, that's the blue column on the left versus the blue column on the right, you can see there's a significant improvement in the bond strength just by adding a drop of this material to the surface. Okay, so from zirconia, the next most or maybe more popular in zirconia is Emax. So lithium disilicate, very strong material, highly aesthetic material. And because of the aesthetics and the strength, has become very, very popular in the dental industry. Many of us are using these multiple times a day as our material of choice for crowns. So zirconia, some of the challenges there, it's a very strong material, but not as strong as zirconia. Lithium disilicate does benefit from being bonded to place with resin cements. It will enhance the strength, therefore the durability of the material over time. It is translucent, so with our Emax restorations, we have to be conscious of the shade of the cement that we're using and understand the shade of the cement can affect the final shade of the crown. Thus, we may occasionally use tri-M paste or the use of a translucent cement so we can create effect or create no effect at all. Resin cements are well known and well proven to bond to lithium disilicate. With good retention and resistance form, you can use either a dual cure resin cement or a self-etch resin cement. Then it becomes really personal preference as long as you have good retention and resistance form. If your resistance form starts to get compromised, I always defer to dual cure resin cements because I know the bond strength is going to be higher with a dual cure resin cement versus a self-etch resin cement. And then in a moment, we're going to get to the protocol of pre-cement treatment of lithium disilicate because it is very different than the pre-cement treatment of zirconia or metals. Okay, and then the last material we'll talk about is feldspathic porcelain, which are used with veneers. And when we talk about veneers, we're using a very thin piece of porcelain to cement on the tooth. That thin piece of porcelain is very often going to be cemented on enamel or maybe enamel and superficial dentin. With PFM, gold, zirconia, and lithium disilicate, a crown prep is basically 100% on dentin. So we don't take enamel into consideration because it's all gone. But when we're doing veneers, especially minimally prepped veneers, frequently there's a lot of enamel left on the tooth. So that, in the most part, works in our favor. We'll talk about that in a second. But that's where the difference in two structures does make a difference in the type of cement. But the other thing about veneers is veneers have no retention and resistance form. And they stay into place entirely on the adhesive capabilities of our bonding agent, our bonding protocol, and the cements that we're going to use. Now, because veneers frequently are being cemented on two structures that is enamel, we are going to use a total etch technique with either a dual or light cure resin. Dual light cure resins have the highest possible bond strength and the bond strength of etched enamel is even better than the bond strength of etched dentin. So if we have a lot of enamel present and we etch that with phosphoric etch, and then we use a resin cement, be it dual cure or light cure, now we've got the highest possible bond strength we can create because of the exceptional bond strength of resin to etched enamel, but also because of the dual cure resin to the porcelain. The shade of the cement absolutely will affect the shade of the final veneer. So you need to be very conscious of what cement you're using, what shade it is. When we get to veneer cements, they're usually come in kits that have try and paste, so you need to try those beforehand to be sure you get the final color you want. So from here, I'm going to talk about the preparation of cements, or the preparation of materials to get to the final cement. So with porcelain veneers, once you've tried them in, with all restorations, once you've tried them in, the restorations are now contaminated. Saliva, blood in the mouth, you've picked up contamination that's now in the internal aspect of your restoration. You need to get that off. If you don't get that off, your bond strength will absolutely be negatively effective. So what I'm showing here, the veneers have been tried in, rinsed off with water. Now we're going to clean the inside of the veneers. Here I'm using a material called Zerclean, and Zerclean is just a cleaning agent that'll go in and get rid of the contaminants from the saliva and blood that was in the mouth, get that off of the porcelain, clean the porcelain back up. So now you have a clean, sterile surface to work from. Before I cement them into place, I'm going to use a silane. So I'm showing here a 2-bottle system. Bisco makes this. And I'm going to re-silanate the veneers. Even though they came back from the lab silanated, I'm going to re-silanate them using a 2-bottle system. And I would point out, using a 2-bottle system is ideal because silane is very volatile. If you get a 1-bottle system, there's a good chance the silane that was in there at manufacturing is no longer in there even by the time it gets to your office. So you need fresh silane, and I highly encourage you to use a 2-bottle system for that. So we try the veneers in, we rinse them off. Now we clean them with a cleaning agent. Again, here I'm using Zerclean. Ivoclar makes another product called Ivoclean. This can work as well. In the old days, before these products, we used to use isopropyl alcohol for 1.5 minutes in the ultrasonic to clean out the inside of the veneers. Okay, so clean, re-silanate, and now we're ready to cement into place. And when we cement into place, we can use either a dual cure resin cement or a light cure resin cement. So we have the teeth isolated here. We're going to do a total etch technique. So we etch the teeth. Bonding agents, a lot of different choices, but just about all of us now are using a universal bonding agent, a number of different ones on the market. This is Bisco's All Bond Universal, which we've been using almost exclusively for, I don't know, the last 3-4 years. The beauty of the universal cement is not only can I use it for bonding my veneers, I can use it if I'm using a dual cure resin to bond in my cements. I use it for my direct composites. This to me is becoming a universal bonding agent to now. I don't carry a lot of different types of bonding agents, but rather I can just go with the one universal system. So here we're showing the etch being rinsed off, lightly dried, bonding agent being placed, 30 to 60 seconds, air thin, light cure. And then my choice is I like using light cured resin cements for my veneers. Dual cure resin cements certainly can be used, but I feel like the light cures have a better handling property, give me a little more time as I'm seeing multiple veneers into place. And also the light cure systems very often come with try and paste. And I'm going to use the try and paste to make sure I like the color of my veneer, or if I need to alter it, I can use it, the try and paste to help me find the right color to get the color I'm looking for in the veneer. So there are a number of different choices of light cure resin cements out there. At the bottom right-hand corner is Bisco's Choice 2, specifically designed for the use with feldspathic or porcelain veneers in general. But I could use any of the dual cure resins. This is just 3 examples of different ones that are on the market. So here I'm taking the light cure resin, loading it into the veneer, seating it into place, cleaning off the excess, and moving on. Okay, so now I want to go to gold, PFM, and zirconia. And how do we treat those? Because we're going to treat those differently. So after the try-in, again, when you try in any restoration, when it comes out of the mouth, you've got the internal aspect of that restoration has been contaminated. So with these 3 materials, and this is why I said back earlier, think of zirconia as a white metal and treat it that way, because all 3 of these materials are all going to be treated the same way. So we've tried in the crown. We take it out. We're ready to cement it. First, we're going to clean the internal aspect. I like using air abrasion. So I take the crown back into the lab, and with my micro etcher, I'm going to etch out the internal aspect. That will get rid of a lot of the contamination, and also it'll start to score, create more surface area on the internal aspect, and you absolutely can use air abrasion on the internal aspect of a zirconia crown to increase the surface area. Well documented and been well proven with recent research. So I know we were told earlier in zirconia's history, but I can tell you now, absolutely, you can and should use air abrasion on the internal aspect of a zirconia restoration. So after we've air abraded, now I go back, and whether it's PFM gold or zirconia, I'm going to clean out the inside with the ZerClean material, because I may not have got 100% of the internal aspect of that crown cleaned with the air abrasion, but I know with the liquid aspect of ZerClean, I will 100% cover all the surface area and get rid of all contamination. So once I've cleaned it, then rinse it out and air dry it. Now I put a drop of the metal primer in there. In my case, I use the Z-Prime material. So put a drop of metal primer in there to enhance the bond strength of the cement I'm going to use to the metal or the zirconia. Okay, so 1 or 2 drops, let it sit for the appropriate period of time, and air thin it. So with these materials, with good retention and resistance form, really any cement's going to work. So if you're in a high carries risk situation, you can use glass ionomer or resin modified glass ionomer. Most of us are going to use either a dual cure or self etch resin. And certainly if the retention and resistance form is compromised, depending on how compromised, I'll be using either a dual cure resin or a self etch resin. So you can see here we're cleaning the preparations. I'll talk about that in a second. And now I am loading the bridge with a dual cure resin cement, seating it into place, clean off the excess, we're done. Okay, lithium disilicate or Emax, that's a different protocol. After you've tried it in, you don't want to air abrade it. Okay, you just want to clean it out. So either isopropyl alcohol in the ultrasonic, 90 seconds, old school way of doing it. The other old school way I used to do a long time ago is phosphoric acid. Not to etch the porcelain, but phosphoric acid is actually a really good detergent. Used to do it that way. Now, what we'll use is the ZerClean, or a lot of people are using the IvoClean material. Either one of those materials are designed to get rid of the contamination, those proteins that are on the surface, get rid of them to increase the bond strength. Then the internal surface, I'm going to treat with silane, let that sit the appropriate amount of time, air thin it. Now I'm ready to cement. I would mention here, with really good retention and resistance form in a low stress area, you could use resin modified glass ionomer. Very few people do it, but the strength of lithium disilicate is such that potentially you could use it. I only think about it when I have a patient with a seriously high caries rate. More often than not, I'm going to use a dual cure or a self-etch resin cement. If my retention and resistance form is compromised, then I'm going to default to the dual cure resin cement. Okay, quickly want to mention, if you're using any of the resin cements, it is really important to have good soft tissue control and not have fluid liquid leaking onto your preparation. So just like when you're doing a composite on a direct restoration, you need good soft tissue control. Same thing here. Same thing as when you're taking your impression for your crown. If you're using a resin cement, be it dual cure, light cure, or self-etch resin, that soft tissue has to be good and dry and isolated. So I mentioned Viscostat Clear here. A good hemostatic agent does a really good job of stopping bleeding. Or the other options that's becoming popular are these putty systems that are used for gingival retraction. Expasil is just one of several on the market. You could use a retraction cord. Doesn't really matter to me what you use, but you need to pay attention because when you're using a resin cement of any sort, your bond strength will be affected if it's contaminated by blood or saliva. And if the blood or saliva is coming from the marginal area of your preparation, that affects your bond strength. So good, proper soft tissue control is really important with any type of resin cement. Quick mention here, a material called Hemoseal Inside. Many people use Gluma or similar materials to clean the preparation before their final cementation. I did that for a long time. I've recently switched over to this material because it doesn't contain glutaraldehyde, but instead uses chlorhexidine. And it's giving me the same results, reducing sensitivity. Some research showing that it may enhance the bond strength. Clinically, I'm definitely seeing that it helps decrease sensitivity the same way that my Gluma was, but without using glutaraldehyde. So just mentioning that. Real quickly on implant crowns, my material choice to cement a crown is a screw. 90% of the implant crowns I place are screw retained and cement isn't an issue. For those of you paying attention to recent literature, we're seeing some issues of implant failures that are being pointed to cements being the issue. I try to avoid that issue altogether and just use the screw as the cement. That being said, not every time can you do that. When I do have to cement an implant crown, I try to stay away from the resins because a lot of this research is pointing back to resin cements causing the peri-implantitis. So I try to stay away from resin cements. The Ceramer cement is a non-resin cement, has good retention properties. So that to me has been my first choice. Glass ionomers I've used for a long time with good success, but it's just this is the one place where I really stay away from resin cements. If you are going to use a cement, a quick and easy technique I saw Bob Margis present years ago. Take impression material, inject it into your crown or bridge, pull the impression material, so you've got an impression material die, put your cement inside your crown or bridge, place it back on this impression material die, squeeze out the excess, and now you have very little cement left in the internal aspect of your crown or bridge, but you cement that into place and it reduces the amount of excess you have to clean off, which may help prevent the problem of peri-implantitis associated with cements. So just a neat little trick that I've used for a long time that's worked well. Bioactive cements we've talked about, and I'm getting a little close on time, so I want to skip to here. So cements, different manufacturers of cements. Glass ionomer cements, we have these different manufacturers available. Dual cure and light cure resin cements, again, a lot of different ones on the market. What I like about Bisco is they make all the different types of cements except for the glass ionomers, but dual cure resin, light cure resin, and this Theracem material is a self-fetch resin cement, which also, again, depending on your definition of bioactivity, could be considered a bioactive cement as well. And that's just some stats on the Theracem. And then just to go through cementing an Emax crown step by step, cleaning the prep with the Hermoseal inside or Gluma, if that's what you use. So get the prep all clean, zero clean on the inside of the crown to clean out the contamination, reselenate. And then this one, I have good retention and resistance form, so I'm going to use a dual cure self-etch resin cement, and in this case, the Theracem. So load the crown, seat it to place, and I'll light cure this for 30 seconds. I'll get an initial set that's very easy to clean with the Explorer. Then we'll do a final light cure, clean it up, adjust the occlusion, and we're done. So to end with here, and I got a little time to get to questions, but one, understand there is no one universal cement, and there's not going to be for a while. So you need to understand the different cements, what they can do, what their strong points are, what their weak points are, and use your clinical judgment, knowing all the information as to which cement is going to be the best choice for that particular patient in that restoration. Each restoration type, prep resistance and retention form and isolation challenge has to be individually tooth by tooth evaluated, because that will determine which cement's going to best suit your needs. Again, understanding the pluses and minuses of each different type of cement. Proper technique is huge. The cleaning process, pre-cementation for each of these materials is a really big deal. Pay attention to that. But keep up to date, because this area of dentistry is going to change a lot as our technology gets better and we learn more. But it's one area of dentistry where, again, because there is no universal, need to understand exactly what's going on. You know, for me, looking forward, the future of cementation is going to have a bioactive component to it, and it's going to have a self-etching component to it. No doubt where that is, when that's going to happen. You know, we're certainly getting closer. We've made a lot of progress in 10 years, but it's still going to be a little while till we have that one universal cement that's good for all particular situations. So I would just ask you to take the time to research, understand, make sure you're knowledgeable about what you're doing, look at each situation as it presents itself, and pick the right cement. So I probably have a minute to get to a whole bunch of questions and answers. Okay, at least get to this one here. Will translucent zirconia be affected by the shade of the cement? Last year, I would have said no. This year, I would say maybe. As zirconias are improving aesthetically, they're becoming more translucent. As they become more translucent, the shade of your cement may, in fact, affect the color of the final restoration. So we have to pay attention to that as zirconia technology improves. So that being said, I am getting the proverbial hook. My time is up. I apologize that I didn't get to a number of these questions on there. Many of them are good, but I am out of time. On this bottom slide, there is my email address. I would be happy to respond to any questions that you have afterwards. Just send them that email, and I will do my best to get back to you as quick as I can. So I thank you for your time this evening and wish you all a pleasant night, and good luck going back to work, everyone. Thank you.